Thank you so much, sir, for the kind words. I'm very honored to be presenting in front of such a esteemed and knowledgeable audience. And this is a relatively novel topic. I have talked about it once in a previous breakfast CME. So today, my job will be just to introduce PET and what is its role in oncology in a short span. I won't take much of your time since more stalwarts are to follow, and I would prefer that you listen from them on their topics. I'll just give a brief introduction so that everyone who may have missed out on the previous lecture or who is joining us now can be aware exactly what we do and how we do it. So, just before starting, I'll like to introduce myself. I am Dr. Aviral Saxena, as Sir had introduced. My PG is from Amrita Institute of Medical Science, Kochi, Kerala. That is one of the leading institutes in the country in many aspects, especially nuclear medicine. And I consider myself proud to be alumni from Amrita Institute. I have started my new venture, that is Crystal Diagnostics PET CT scan, as Sir had introduced already, that it's a digital PET CT scan, which is the most advanced in the state and the city's first. So these are some pictures of our institute and how we generally function. So I'll get straight to the topic since we have more speakers to follow. So first thing I'm going to introduce is how does PET imaging work? So we already know how an X-ray or a CT or an MRI works. I think most of you might have heard in some lecture or would have read about it, and you have seen it for so many years. So how does PET imaging work? So PET imaging generally works with the help of a radio labeled tracer. So this tracer is generally given either intravenous or in some cases even orally, but maximum it is given intravenously. So what does this tracer do? Once it is injected, it will go into the bloodstream and go into the target organ. So most commonly, as I'll talk about, our target organ will be, since we are using a tracer which is glucose based, so our target organs are based on which take up glucose more, but it can be any tracer. It can be a receptor targeting, it can be a simple physiological or a pharmacological agent, which we use. Any drug that you are having can be radio labeled and can be used for imaging, and we can study its pharmacokinetics. So once we give this radio labeled tracer, so yeah, so once we are giving the radio labeled tracer to the patient and it goes to the target organ inside the patient, how do we really detect it? How do we know where it has gone? So it is detected by the help of an annihilation reaction. So that is the main principle of PET imaging, that is positron emission tomography. So this is a positron which will emit something. So that emission is actually a gamma ray. So gamma ray is just equivalent to an X-ray. So it is emitted in both directions. As you can see, the PET detector has a ring in which it is detected in two planes, 180 degrees to each other. And with the help of that, we are able to tell exactly where it is coming from in the body. So it is slightly different from an X-ray, where you give an X-ray to the patient, and once it passes through the patient, you are able to tell, okay, what is the structure of the body. Here, since we are not talking about a structure, it will go to the target organ, and from there itself it will emit, which we will be able to detect. So similar thing is shown in the other diagram, which is slightly more explanatory. That is, we are using a 511 keV gamma ray, which is the energy for all positron emissions, and it will be detected in a PET scan. So how does a PET scanner work? I think most of you would have heard the word PET CT or PET scanner. So both are the same. PET CT and PET scanner are now equivalent. Initially, the scanners were equipped only with a PET detector. Now, all the machines that are coming in the market always have either a PET CT or, in very, very rare cases, in some research institutions, we have a PET MRI, as we had in Amrita. So that has few indications, but for all practical purposes, PET imaging means PET CT. So the PET CT has a helical CT and a stationary PET. So the CT will work like a CT machine, while the PET will not move around the patient. It will be stationary. So patient has to move through the scanner, and different body parts will be scanned once the patient is moving inside the scanner. So we generally do a whole body PET CT. So once the CT is done, the PET will cover the whole body in some time. That time varies from scanner to scanner. So this is our machine. So this is in our institute, our own images. So this is a digital machine. So generally what we have here is we cover the whole body in less than 10 minutes. So the entire scan is actually over in less than 10 minutes, which previously used to take, I think, even in some centers, still it takes 20, 25 minutes, even up to 30 minutes. So then let us talk about what do we inject? We inject some tracer. So what is that tracer? So for all practical purposes, 90 or even more than that, maybe 95% of the time, what we are talking about in PET is F18 FDG. So this is known as the molecule of the millennium, because once it was discovered, it was found that almost all malignancies and multiple other non-oncological disorders, as sir will talk about later, can be detected with the help of F18 FDG PET. So how does this work? So it is a glucose analog. Just like glucose goes into the cell and it is metabolized, this also enters the cell through the GLUT receptors. Once it is inside, it is converted by hexokinase to FDG6 phosphate. Beyond that, it does not undergo metabolism and it is stuck in the cell. So the cells which take up more glucose will have plenty of FDG inside. So the more active cells, which is specific for, I can say, cancer cells and some rare, some active infections also will take it up. So this will metabolize and it will stay in the cell. Once it is inside that cell, we'll be able to detect it with the help of PET imaging. So it has high sensitivity, relatively lesser specificity, since it is used for so many cancers, so many diseases, so the specificity is bound to go down. So how does it take up in malignant cells? You would have thought, what is the special purpose? How we are able to detect malignant cells with such accuracy that PET imaging is known all over India as the cancer imaging. So there are two main things. One is the Warburg effect. Normally what happens is glycolysis. In pasture effect, what happens is if there is no oxygen, in anaerobic state, there will be glycolysis. But Warburg effect means the cells will, even in the presence of oxygen, they will take up only glucose, which is a less used pathway in normal cell. So because of the Warburg effect, and there are some other properties of malignant cells, that is the GLUT1 overexpression, the increased hexokinase activity, the decreased G6 phosphatase activity, which is the opposite direction, and HIF activation. All these together will lead to more FDG uptake in the malignant cell. So before we go to the case scenarios, since I thought case discussion would be better suited today, since it's easier to understand any new thing case-wise, I'll just first introduce what is the normal distribution of FDG so that you are all tuned to it. So what happens is normally FDG is taken up in many of our normal cells, like brain. As we all know, brain uses glucose the most and it's the preferred substrate. So all patients will have glucose uptake or FDG uptake in the brain. Apart from that, other physiological sites include, but are not limited to, oropharynx, esophagus, myocardium, and it is excreted via the renal pelvis into the urinary bladder. And you can see the urine in the urethra also in the second image, because the patient might have voided but not completely able to void. So that is why we are seeing some physiological signs. So that is all normal that we are aware of. Apart from this, if it is taken up anywhere, we will be able to classify those as pathologic. So the general indications include almost all cancers, except one or two very slow growing cancers, one of which is prostate cancer, which we'll talk about in the next session. So most cancers, including pediatric malignancies, can be detected with the help of FDG PET, and not only detected, it can use it for staging, restaging. Then response evaluation is a big role of PET, because no other modality can claim to give a very effective response evaluation as well as early response evaluation compared to PET. Then any chance of recurrence in FDG PET is the best imaging for surveillance and treatment planning as well. Apart from these general indications, there are some specific indications which we find in day-to-day life. One of which is localization of an unknown primary, guiding the biopsy, because you need to know which is the most active site. Then your biopsy yield will be best. Sometimes what happens is you take a biopsy from a blind site and you get it as negative, or you don't get a good enough yield. and the patient will be lost to follow up for 2 or 3 months. By the time his malignancy will grow. So guiding the biopsy is a very, very important role. Apart from that, it's a prognosticatory tool also. A patient with a very high FDG uptake in its tumor versus a patient with a low FDG uptake. The prognosis of the high FDG uptake patient is poor because it translates to a dedifferentiated disease. So a patient with a poorly differentiated carcinoma is bound to have higher uptake compared to a well-differentiated carcinoma. So all of you must be thinking if there is any contraindication for PET-CT. So there is no contraindication except a pregnant woman. So pregnant woman, as we all know, we are not even allowed to give an X-ray. So this is a PET-CT, so it's an absolute contraindication. We don't do for pregnant women. Apart from that, breastfeeding mother, it's a relative contraindication. I say relative because we do it most of the times for breastfeeding mothers, because if it's already an oncologic related disease, so you have to treat it. So even breastfeeding mothers, we'll give some precautions to follow for the next day, and we'll do a bit. It can safely be done in all other cases like small children, CKD patients. We'll give without CT contrast. Patients with allergy to iodinated contrast, we will not give CT contrast. And CLD patients, even ICU patients, we can do. It is only advised not to do in patients with fever or hemodynamically unstable status. But if the patient needs it urgently, we'll still do it. There's no contraindication from our side. It's only that because the procedure takes a bit of time and it's a non-hospital setting generally, so it's generally avoided. I'll come to the case scenarios. So most of the scenarios are actually my own experience for the past 2 months. So one of this is a lung nodule characterization. This we found very commonly in routine practice. What happens is you send a patient for a chest CT or even a chest X-ray, you will find a nodule. You don't know what to do with it. It looks suspicious, but whether it needs immediate intervention or not. So the first case, we can see, the first case, this nodule was there on CT, while patient was referred for an FDG PET, which showed good FDG uptake in that nodule. So this is the yellow part. The more yellow it is having FDG uptake, while the red is having no FDG uptake. So since it was FDG positive, we took a biopsy. It came out to be malignancy, and the patient was treated as such. Another similar patient, the second case, there's a similar nodule, maybe slightly differently looking, but it looks suspicious on CT. So the patient was advised for an FDG PET. The FDG PET did not show significant uptake, and the patient was followed up with CT. And later it came out to be non-malignant because the CT wise it did not have any other characteristics. It was followed up for 2 years and they did not show any significant increase in size. So it was the biopsy was avoided in this patient, and the patient's anxiety was also relieved at that time. Then coming to one of the most common carcinoma that is there, breast carcinoma. So a patient comes to you with a locally advanced carcinoma breast or a high-risk histopathology. How do you proceed? So I'll advise you to go for a PET. But why? What is the need for a PET? I'll show you 2 or 3 cases. So the first case is a locally advanced carcinoma breast. So in palpation itself, the nodes could be felt. A large mass was there. So the patient was referred for a PET. What we found is this was the main tumor, this same tumor, and there is a tumor in the other side. That is the node which is on the other opposite breast. So this is the opposite axilla. So that made it metastatic disease in itself, but we found other lesions, especially one in the liver. So it was a metastatic case. It went for palliative care. So not ideal for surgery, even though it's a clinically palpable case. Then second case, similar case, there is a lump in the left breast. So that left breast lesion is showing high FDG uptake, but there is no node or any other lesion in the whole body. So this patient was safely taken up for surgery, and the histopathology came out to be infiltrating ductal carcinoma, but the lymph nodes were also negative, and since the FDG PET showed that there was no metastasis, the patient can be safely continued on some basic treatment. The third case, this case was actually referred to us as a case of CA breast with suspected liver lesion. So ideally what would have happened in a if there was no availability of PET, this patient would have gone for palliative care. But since this patient was sent for staging as such, what we found was that the liver lesion was actually some anatomical abnormality or some just heterogeneity that was found in an ultrasound. They did not show any significant FDG uptake, and there were no other tumor nodules in the entire body. So this patient benefits from that. Instead of going from palliative care, this patient now will be given the option of a surgery, a radical mastectomy, and can be safely followed up. Then something that is very common in our region, I think most of the surgeons will agree with me, carcinoma gallbladder, or even a suspicion of a carcinoma gallbladder is very, very common in our city. I was there in Kerala, I did not see much carcinoma gallbladder, but since I have come here, I think in the past 2 months itself, the number of cases which I have seen is more than what I had seen the 3 years in Kerala. So first case was a carcinoma gallbladder that looked suspicious on CT, no biopsy done yet, but it looks suspicious, so they did a PET. So this is the gallbladder tumor on CT, and this is on the PET, that uptake you are seeing. But what we found was there are other focal uptakes in the liver, and there are multiple focal uptakes. So this actually is a case of metastatic carcinoma gallbladder that you cannot directly take up for surgery. Then in similar case, what happened is another patient with a gallbladder mass then was taken up for PET. So we showed a lesion in the gallbladder that is infiltrating in the adjacent liver. Only based on that, we would have thought that maybe, okay, you can take up this patient for surgery. But what we found was there's a nodule, there's a omental nodule that is adherent to the bowel that is showing high FDG uptake, which is most likely a metastatic nodule. So this patient is again unfit for surgery. So the management changed. While I had many cases, actually, I did not include many cases. I have some cases that were only, of course, limited to the liver and gallbladder. So they were taken up for surgery. I wanted to include some interesting cases. So one more case that we generally see, carcinoma gallbladder post chemotherapy. So patient did not want a surgery. They wanted only a chemotherapy. So the CT scan showed some suspicious lesion. What we found was that the liver also had some infiltration, some nodules, and there's a gallbladder mass which is showing high FDG uptake. So definitely a recurrent disease. While another case, the patient went for a cholecystectomy. That was a simple cholecystectomy, not a radical one. And patient also went for chemotherapy since it was not a radical cholecystectomy. So the patient then presented with on an ultrasound suspicious looking gallbladder or a liver lesion. So this was confirmed on the PET that there is a nodule actually in the gallbladder bed, where the post-operative bed, which is infiltrating the adjacent liver segments, that is the segment 4B and 5. So this patient probably can be taken up for surgery because it's only a limited disease. There's no disease in the rest of the body. If the patient wants to go for resurgery, they may opt for it. Then something which is again very common for our region is oral malignancy. Because of the tobacco and tobacco-related products, we have a very high spike in oral malignancy. So how do we help there? So the first case which we have is a case of newly diagnosed CA buccal mucosa. So there's a small lesion, but patient went for a PET to confirm the extent of surgery, whether the lymph nodal dissection needed to be only supraomohyoid or it had to be an extensive one. So what we showed was there is a focal uptake here that you can see, which is localized to the buccal mucosa, and there is no FDG positive lymph node. So this patient can be given the option of a limited surgery and followed up instead of a very extensive neck dissection. While another case, what we had was a carcinoma right buccal mucosa and right lower lip. So this patient was treated, given I think some surgery also was given to the patient previously for the CA lip. Now the patient had a recurrent looking lesion. So what we found was a very big lesion that is abutting the mandible, but no distant metastasis. So this patient again becomes a candidate for surgery instead of going for palliative therapy. Some follow-up cases that we got. One case was a poorly differentiated squamous cell carcinoma. So surgery done recently, and after the surgery there was a CT done which reported a lung nodule. So now the management was initially to go for only radiation, that is radiotherapy. But because of the lung nodule, they were planning for a chemotherapy. But the oncologist decided to go for a PET. What we found was definitely there is some maybe a tumor nodule adjacent to the flap. There is one node that is positive in the neck, but the lung was clear. There, the lung nodules did not show significant FDG uptake, which in a poorly differentiated squamous cell carcinoma should be there in such big nodules. So, patient instead of going for chemo radiation, they can go for simple radiotherapy and can be followed up. While another case, this is a well-differentiated squamous cell carcinoma. Patient did not undergo surgery. They underwent chemotherapy and radiotherapy. And then the patient was planning that, can I have a surgical option so that it improves, my survival chances improve. So they did a PET. What happened in the PET was the primary lesion was there. Apart from that, there are few nodes in the neck, and there is one node in the hilar region and multiple nodules. So this case actually then became non-operative. And even though the nodules actually did not per se look 100% malignant, but patient was given the option either to confirm via biopsy whether the hilar node or any of the nodules is metastatic or not, then only we can plan for surgery. So maybe one unnecessary surgery or one surgery where the patient would have come back and told, sir, you did surgery, but still I am having the disease. So that was avoided. Then there is something where we have a very huge role, that is lymphoma. So lymphoma actually, the recent guidelines state from the first step itself, that is initial evaluation, you have to do a PET. Then when you start chemotherapy, there is something known as interim therapy response to see whether the chemotherapy is working well or not, whether you need to either increase or decrease the treatment based on your interim response. So after 2 cycles or 3 cycles, there is an interim therapy response. And then at the end of the completion of 6 cycles, there's an end of treatment. So this is a usual protocol. Then again, if there any surveillance or recurrence is suspected, then we do a PET. So 3 to 4 times a lymphoma patient undergoes PET. So why? So I have taken some textbook cases from Indian Journal of Radiology. So first one is showing a lymphoma patient. You can see there are multiple uptakes. So to accurately stage the disease, you cannot use a regional modality, suppose a CT or an MRI of a single region. First of all, you have to do for the entire region. So we do a whole body scan. So the whole body CT as well as whole body PET. So we are able to exactly localize where and all the disease is at the initial stage so that the treatment response is accurately assessed. Then why not do only a CT? The second image will show you. This is spleen, which looks very, very normal. My radiologist friends would be there. They'll see and they will find no abnormality with the spleen. But we found a diffuse increased FDG uptake, which is generally seen in cases of lymphoma. That means a lymphomatous involvement of the spleen. Then what is the other indication? The other indication is a biopsy planning. So this is a case where the huge axillary node is there. So either if you do a single CT, you may think this is a very huge node. Patient may have multiple other nodes. So whole body we evaluated. There is no other site. This is only a localized site. And you can also tell exactly from where to take the biopsy. Then this same patient, once the biopsy was done, the patient was treated. Post-treatment, you can see the FDG uptake, compare this and the last image. This huge black mass has disappeared. That means the treatment has worked. While on CT, there is still some disease, but PET-wise, it has almost disappeared. So you can actually tone down the treatment or you can stop the treatment if it is complete. Then one more, I think one of the last cases I have to discuss is lung carcinoma. So all cases of lung carcinoma ideally should undergo an FDG PET for staging. What will we find in an FDG PET on lung carcinoma? An FDG PET was done for this patient with a biopsy-proven lung carcinoma. What we found was there's only that nodule and nothing else in the whole body. So this is a surgically resectable case. Well, another similar case, there was a big lesion in the lung. Then on PET, what we found was there are multiple other metastases. There are bone metastases to the hip bone, to the sternum. There are multiple metastases. So this is not a surgically resectable case. So this has to go for a palliative therapy. These were the end of the case discussion. Just a small point. Since I was talking digital, PET, digital, what is digital? How does it help the patient? So there are definitely many advantages as I have enumerated. The most important of those being, firstly, we reduce the radiation dose to the patient. Even though PET itself does not add too much of a radiation, even though it's a radioactive, so everybody will think it's a very high radiation exposure. it is actually very low. But even that low, we have reduced to half of its value. We have improved the time from 20, 30 minutes. Now you can do a PET scan within 10 minutes. Apart from those two things, even after lowering these two things, you can actually get a very, very good quality image that is better than the previous analog scanners. So all in all, it's a full package for the patient. So it helps the patient, it helps the clinician, it helps the person who's reporting the PET. I'll show you some examples if that was not convincing enough. So this is a digital PET-CT image, very small lesion in the liver. When the same patient was taken up for an analog PET-CT, there's no lesion detected. So the small lesion can actually be missed on an analog PET. Then there is a brain scan. You can see the difference between the brain scans between an analog PET scan and this is another company, Verios, digital PET scan. So you can see the sulci and gyri are actually not very clearly demarcated. You can see the clarity in this image versus this. Then one more case. So there was a very small nodule just behind thyroid. So this is a parathyroid adenoma case actually. So it was not detected on an analog PET-CT, but in a digital PET-CT that was detected. So you can actually pick up more lesions in a digital PET than an analog. Next, I'll just introduce the coming two speakers from my side also. They are my teachers, my guide. They have really helped me a lot while I was in Kerala. I have all I know, I owe it to them. Dr. P. Shanmuga Sundaram, Dr. Padma Sundaram. Both of them have single-handedly actually taken Amrita's nuclear medicine department to unrivaled heights. It is the, if not the premier most, it is one of the top 3 institutes in India in nuclear medicine. We boast a PET MRI, which is, I don't think it is there in more than 2 or 3 institutions all over India. And sir and ma'am are actually celebrating 25 years of nuclear medicine in Amrita, and they are doing very nice educational programs all through this year because of completing the 25 years. And they have actually transformed the entire landscape of the South India, how they approach nuclear medicine and how they approach not only PET-CT, but the other part of nuclear medicine, that is the therapy and gamma camera. Everything what is there in Kerala especially has been after Sir's image. Each of the reports or each of the pattern which you see has some of Sir's style in it because he has shaped it so much. So on that note, I'll thank you. I'm open for any questions.